Thank you very much. So this talk will be very practical, how I started robotic liver surgery and the pathway I followed to become a robotic surgeon. So it's the final talk. The first thing that is very important if you want to implement robotics into your practice is knowing that robotic surgery is total competition. I stole the name from a book written by Ross Brown, the engineer that helped Michael Schumacher to 7 world titles. And in this book he explains that, and I think in robotic surgery it's the same, it's not about the car, it's not about the technique, it's not about the driver, it's the whole concept. The economics, politics, data, so everything is important if you want to get good results. And that's something you have to keep in mind during your whole pathway of training and during your implementation phase. I'm also a big fanatic of data. I think you can only know what you're doing if you track your data and you analyze your data on a regular basis. I have shifted several times from another technique to another one just by analyzing my own data. So every 6 months we go through the data, we look what happened, we look if we have similar complication rate, if something is different, and then we adapt the technique based on the analysis we're doing. So actually I want to talk about my personal journey and learnings in the transition from laparoscopy to robotic surgery. This is a very important paper. It was published in 21. The data was collected in 2020. It's a survey among high-volume European centers, and it was actually a questionnaire, so only high-volume centers were included. How many of your cases of liver surgery are you doing laparoscopically or robotically? And only 1 in 3 patients was offered minimally invasive surgery. I think the reason for that is actually the long learning curve for laparoscopic liver resection and for robotic liver resection, few high-volume centers, and until a couple of years ago, we had lack of robust evidence on oncological safety. So actually in 2020, I performed 65% of my cases laparoscopically. So you might ask, why would you start robotic liver surgery if you have 2 in 3 patients offering minimally invasive surgery? What's the big advantage of doing that? Well, sometimes you have a gut feeling that there are indications that you're doing open, but if you had advanced technology like endorists, these might overcome the hurdles of minimally invasive surgery. It's a little bit the same story as we have seen with Michael Schumacher, who was 2 times world champion with Benetton. So why would he shift to Ferrari, who was a very bad team at that moment? So in '96, Ferrari was nothing. But still, he and Ross Brown felt there was something to gain. And then eventually, after 4 years of waiting, he became another 5 times world champion. So, you know, sometimes you feel there's something you can gain and you have to go for it. But the most important thing is you have to track your data. So if you ask me, why did I switch to robotics? Well, actually, I thought there was something behind laparoscopy. Because I think robotic surgery is mainly made for indications beyond the limits of laparoscopy. And then this is a classical QSUM analysis. The main goal of your training should be a non-existing new learning curve. So you have to try to push the learning curve up and to shorten it. Because we cannot allow our complication rate to go up because we want to start to implement a new approach. So that's another lesson I had in mind when I started robotic surgery. So what are the advantages? We know we have wristed instruments, tremor cancellation, enhanced dexterity, 3D vision, and as I mentioned before, liver surgery is more like open surgery. You have all possibilities. We have seen the paper of death of laparoscopy. It was quoted by one of the other presenters, which was published in Surgical Endoscopy. They talk about all different types of complex abdominal surgery, but not about liver surgery. It's like liver surgery is coming behind. So in line with a textbook that we will publish in January on robotic liver surgery, I asked my good friend Ruben Siriwa to go to the literature and to give a forecast what will happen with liver surgery. But you can actually see the same. It's just a little bit slower, but I think 2030, you will see that you will have a crossing of laparoscopy and robotics. So there was a problem because when I started robotic surgery in 2020, robotic surgery was still in the pioneering phase. That was a big difference. When I started laparoscopic liver surgery, 2012, we had a lot of people we could go and watch case observations. There was nothing in 2020 for me. So I had to think about how can I implement robotic surgery in a safe manner. Because we were in the pioneering phase, and mostly because I should avoid having a new learning curve. Because if you have more complications, you have a problem. Luckily, I had the data of all my laparoscopic cases, and we could compare on a regular basis. Because you have to stay humble. If you're a good laparoscopic liver surgeon, it doesn't immediately mean you're a good robotic liver surgeon. If you look at the Formula One, the training starts in the simulator. These people train for hours and hours and hours in the simulator. So I spent 40 hours in the simulator before I touched the robot, touching a cadaver or a porcine model. So I know these exercises are very stupid, but the goal of the exercise is not to think about the robot, to think about what you have to do in surgery, not about what pedal or what button you have to touch. It's about intuition. So this can be done in the simulator. After simulator training, I went to a lab, and I had some problems with intuitive, but I said, I'm not starting robotics if I cannot have my nurses coming with me to the training center, because I also do colorectal and hernia surgery. If you have a problem during the operation, in hernia or colorectal, you have time. You can solve the problem. You have time. Everybody can think what you can do. And liver and pancreas is bleeding. You don't have time to think. Everybody has to be online. So they agreed to train my 3 nurses, and you should have a dedicated team surrounding yourself, because it's all about those crucial moments when we have bleedings, when we have big complications, that everybody has to stay calm. You have to trust people. They're at the patient bedside. You're in the console. So therefore, I took the nurses with me. We have more than 100 OR nurses. 27 are doing abdominal and urology, and 3 of them are doing all liver and pancreatic cases. This was what I had in mind. So I did the simulator training. I went to Orsi Academy, which is similar as to IRCAT or other centers. And then I had to think, how can I start robotic surgery? I don't think a cholecystectomy is a good idea, because it's just putting 2 clips and burning a little bit. You need to think about a very easy surgery that has components that you need for complex surgery. So for pancreas, you need suturing. You need fine dissection. For liver, you need fine hydrodissection. So a TAP procedure was ideal. Dissecting the vas, the gonadal vessels, suturing, deploying the mesh. So I started contacting Philippe Muisoms from Ghent, who's a proctor for Intuitive, and we did a couple of cases, inguinal hernia. He said, you should do complex, but I said, no, I'll start off with inguinal hernia. I didn't want it to do complex hernia surgery. It was just a training model. So by doing some easy cases of inguinal hernia, then I went to distals, parenchyma-sparing liver resection, and the end goal was actually Whipple procedures. To be honest, I was thinking about an 18-month implementation time before doing the first Whipple, but we had experience with laparoscopic Whipples. We had experience of a lot of laparoscopic hepatectomies, and everything becomes more easy. So if you take time, start with the right procedure, you will go quite fast. But the goal must be to go slow, but eventually you will see that you get along and it goes faster than you think. So it took me 5 months for the first Whipple. But start with easy cases, and then you build up. And based on your previous experience in laparoscopy, you will feel when you're there. You'll feel the moment you have it, and then you can continue with the next step. So this slide I have already shown you, so you have to select the right cases and the right moment. Track your data. I think this is of paramount importance. If you have a database that is really updated every day I operate patients, everything goes in the database. 150 parameters are kept in a database. It's crazy what you see, but then you can analyze what you're doing. So then you get this. Then you get a full analysis. I can have this every day. So you check everything. You check your difficulty scoring system. You check your blood loss. You check your operative time. You compare to your laparoscopic cases. And I think that's the only way you can have a quality control. I'm not including the data. It's my study nurse, but you know, she's my best friend. She knows how I work. I just send her the name, the date of birth, and I make my reports, my OR reports, specifically for the database. So she knows where she can find everything very easy. So then you get a full analysis showing you your blood transfusion rate, your conversion rate, your Pringle maneuver, resection status, repeat hepatectomy, semi-prone position. It's very rare in robotics. How many patients did you use staplers? And that's what's surprising. So I didn't use CUSA, and you see a drop of stapling from 48% in laparoscopic to 21% robotically. So that's quite interesting for a financial analysis. So we also made a financial analysis comparing robotics with the pure robotic approach, comparing that with laparoscopy, because as you have seen, there's also a two-surgeon approach, which is less cost-effective. So this should be stipulated in data and in publications. What type of approach is the surgeon using? So this is everything you get. So I think it's very important to track your data, and not every day, but at least every 2 weeks you have to look into your data. So then you get this comparative study. Actually, the idea started when I did 2 years of liver resections. I promised the CEO of our hospital and the financial director to give a financial report on robotic liver surgery. Is it cost effective? What's the difference? If there would be more complications, or if the percentage of minimally invasive cases didn't went up, why should we continue robotic surgery if it was not cost effective and there was no increase in minimally invasive surgery? But eventually the results were quite interesting, and we published them in World Journal of Surgery last year. So immediately we saw that we did more complex minimally invasive hepatectomies in the initial phase of robotics compared to all our laparoscopic cases. And we did more minimally invasive repeat hepatectomies. So this is an analysis of 630 minimally invasive resections, 450 lab cases, and almost 180 robotic cases. And this is quite interesting. So it doesn't take into account the capital cost of the robot. We had it for prostatectomies, but this is the cost of the length of stay, complications, the cost of conversions, readmissions, or time cost, and the cost of the instrumentation. So in 82% of the cases, I'm only using 3 instruments. Of course, that's not the case with a CladScan. You need a suit, you need a needle holder. But if you do like a segment 8 resection, why would you take a needle holder to put 5 stitches on the corners of your resection? You can just do it with a synchro seal. You don't need to. You need to take what you need, but you need to think twice. For a Whipple, for a CladScan, you need everything. But for normal resections, anatomical or non-anatomical resection, most of the time 3 instruments is okay: bipolar, monopolar scissors, and 1 sealing device. And then you get this, you get a reduction in cost. So this is quite interesting, because most papers are published have a severe increase in cost of CUSA and stapling devices. And this is, to me, the most convincing part. So before 2020, I didn't do any robotics. So we looked at the impact on open surgery. So we went from 32% open cases to 11% open cases. So the reason is we're doing CladScans, intrahepatic cholangiocarcinomas, biliary reconstruction, so everything is done robotically, what was done open previously. So this is the percentage we gain. Training in robotic surgery, I think that's the next big question for this talk, and I think we should try to increase the worldwide diffusion of robotic liver surgery by giving international training programs. So I really like doing that, because you meet a lot of interesting people, you have new friends, you have good connections, you can do studies, you can share data. So I like doing case observations, on-site proctoring if I have time. I like to go abroad and do some training elsewhere. Furthermore, we are also now working on a course for CladScan tumors, which we will start next year in Barcelona. And this is the TR300 course. And in November this month, we have the first international robotic-assisted hepatobiliary surgery masterclass with Iswanto Sukandi. And then I invited Abu Hilal Ladrugetti Di Benedetto, Rutger Zwijnenburg from Amsterdam, and also my anesthesiologist. He will give talks about anesthesiology and robotic liver surgery. And this is something we're awaiting in January 25. So me and my best friend Sukandi is really, he's a golden boy. He's a very honest guy. He's a fantastic guy. He's from the US, but he's a very normal guy, and I really like him. I love the guy. So we had the idea to give it a go for this book. It took a lot of time. It took 2.5 years to get it, because we were waiting for chapters that are very important, also on living donors. So normally in January we'll have the book published. So to conclude, some tips. I think the first one is start with simulation training. The second one is train the whole team. Don't train the surgeon, but train the team. It's a team effort. Start with dry lab, then go to wet lab training. Go slow, make a good case selection. Learn from experts and pioneers. go for case ops and proctoring, and finally track your own data. And I have a small surprise, just to show the impact of training in a team. This is something I have seen this summer in Hungary, in Budapest. At 1 meter, I was able to see the training of a pit stop of McLaren, who has the world record, and watch, because it's very fast. So it's a training, there's a mechanic in the car, they just pushed in the car and they did it 10 times, half an hour before the race. It's impressive. So there they go. I think it goes too slow, so the tire is already on it, so there was something going wrong, but I can try to show it again, but it's very impressive if you see it. I will try to do it again if it works. So that's the difference between losing or winning a race. Thank you.